Thank you very much. And I'd like to thank the organizers for having me here. I have been to Australia many times, and I can tell you it has never disappointed me. It was great to see all my friends again and to make new friends. And what I'm going to speak today to you is pediatric sepsis in the developing world. And I hope at the end of this session, we will all agree that the issue of pediatric sepsis in the developing world is neither one for the pediatrician or the adult physicians. It belongs to all of us. I was reflecting early on about this session and realizing how far critical care has come, in the sense that when we think about the critically ill patient, especially children, we think about it not as a location in an ICU where the care is given, but across the board wherever critically ill patients are. Now, why pediatric infections in the developing world? The problem in the developing world is very different from many of the areas in which we work, in which we have a great deal of resources. And while in many cases we do not think we are well-resourced, this comes from this book, The Innovator Prescription, which holds very true, and it is very apropos to this discussion. As he said here, in the developing countries, the notion of somehow replicating the systems of the developed world is simply unthinkable. The only option seems to be adequate care for the rich and little for everyone else. And you will see how this plays out in pediatric infectious disease or sepsis. The point is that if you look at this graph from worldmapper.org, you will see that the wealth is the top half of the graph gives you an idea of the landmass in relationship to wealth. And while this has changed in the last few years because of the global issues we are having, I can tell you it's probably even more skewed because the poor is not getting any richer. And if you look at the under 5 deaths, there is a reciprocal arrangement with much of the deaths, in fact, 99% or more, occurring in sub-Saharan Africa and in Asia. You can see North America, South America almost disappear, and Australia is non-existent. But I hope at the end of it, we will come to the realization that this is something that we all need to deal with. Global child deaths. There's good news, bad news, in that if you look at this, most of the deaths of children occur because of infectious causes, lower respiratory infections, malaria, diarrheal disease, superimposed nutritional disorders, AIDS, etc. And many of these deaths can be prevented by a very simple treatment. So that's the good news on the one hand. If you look at the number of global life years lost by cause, and this is both adult and children, you can see the tremendous contribution of infection to this. You can see lower respiratory infections, malaria, sepsis, and other, typhoid, measles, and it goes on, whooping cough, etc. So again, we can see the tremendous burden there. So in the next little while, what I'd like to do is talk a little about the stark reality of what we face when we talk about pediatric sepsis in the developing world, and then talk a little about a need for a broader conceptual framework of how we think about sepsis, some innovative ideas. I'd like to mention advocacy a little, and then some concluding remarks. So some of the good news is, if you look at the global trend in child deaths, this is a recent Lancet paper, you can see that the number of deaths on the vertical axis in all fractions has been decreasing. So that's the good news. If I was standing here about 3 or 4 years ago, I would say it was about 10 million children dying. Now it's a little less than 8 million. The point is that's the good news. So malaria, measles, diarrheal diseases, etc., we are seeing less deaths. Well, the fact is that we should not rest easy because of that. If you look at this, this is an issue of the global burden of disease. The top graph shows that in 2000, we have non-communicable disease, which is most of the disease I mentioned, contributes 46% of the global burden of disease and mortality. By 2030, what is projected is that 66% of the diseases in the world would be non-communicable, and mostly this is the contribution from adults, where you're going to have diabetes, hypertension, heart disease, etc. It is predicted that communicable disease, maternal and perinatal conditions will decrease to 20%. But if we look at the data a lot more closely, 20% of cancers, which is going to be a big part of the adult population, at least 20%, are caused by infections. Many of the the herpes virus, etc., contribute to cancer. And if we look at the other diseases, the non-communicable diseases such as diabetes and hypertension, it has now been shown more and more that at least diabetes, it is a harbinger or it is a setup for infection, mostly TB. So the global burden of disease, while this may look sort of promising for infections, it is probably not the whole picture. What is worrisome is that if you look at this graph, it's gives us an idea of the money that was gone to official development assistance to maternal, newborn, and child health over the years. On the vertical axis, you can see the amount of dollars in millions of dollars. On the horizontal axis, you can see the year. And where the arrow stands, you can see around 2008 or 2009, since then, what has been worrying many in the world is that the funding or the amount of money is given for the first time in history has flattened out or even decreased. And it has been because of the global collapse of the economy. So this is very worrisome, and this may cause the trend that we're seeing in decreasing mortality to change. Indeed, several things. If you look at this, this is a graph from Gapminder. On the vertical axis is child mortality, 0 to 5 per 1,000, and the horizontal axis you can see GDP, income. The blue countries are countries in sub-Saharan Africa, and for the most part, if you look at from many years, from the 1960s or whenever they were tracked, 65, 54, etc., the decrease in under 5 mortality has stagnated and in some cases reversed, as opposed to countries like Japan, United States, Chile, Turkey, where the trend has continued down, where under 5 mortality is very low. And now there's a major discrepancy in the world, whereas in low-income countries, children in 1990 were 14 times more likely to die than those in high-income countries. Now it's 18 times, and most of it is from infectious causes. Why do I include mothers? I think it's very important that we think in terms of mothers and children, because this has been shown again and again, of those mothers who died during childbirth or in the perinatal period, the infants who survived the death of the mothers, only 10% live beyond their first birthday. And of those children who are under 5, in fact, 50% of those will die within the next year, within the next few years. So the point is that one of the most egregious things in the world is the maternal mortality, and when we look at it, it's a rare event in much of the developed world, but it is very much a problem in the underdeveloped world, in the area where many of these children are also dying. So when I say that we need a broader conceptual framework to look at sepsis, this is a slide that was given to me by a colleague of mine, Jerry Spiegel, from the School of Population and Public Health. If you look at the diseases, neglected tropical diseases, and the others listed there, sepsis, diarrhea, etc., these are where we work, at a coalface where the individual comes in with a disease. And in most cases, even when we work in global health, we look at different things: efficacy, effectiveness, delivery, how do we scale up various treatment for these conditions. And we think that this will somehow bring human security. Well, the problem is that unless we look at the bigger framework of this, we are always going to be in problem. The point is that, and I'll speak a little bit more about it, the reason why these kids get these infections, we need to investigate that, because in many cases, the number of children who die in hospital there are more children that die within the next 6 months a year when they are discharged from hospital. And I think part of the issue is we take them, they come from an environment that predisposes them to infectious conditions. We treat the infection conditions and we send them back to the very same environment, and lo and behold, we see the results of it. So the proximate causes in the family and community, malnutrition, water, sanitation, etc., we know these sort of issues will lead to infectious diseases, but the intermediate one are really poverty. In a sort of, let us be frank about it. We can talk about the different issues, disparity, access to education, gender issues, civil strife, etc., but it comes at a community level. It is due to poverty. And then the underlying issue comes at a government level, interest, wealth, status of women, land tenure, weak governments, etc. Now, these are the causes that really lead to infections. And while we cannot solve the entire issues, the issue of understanding this, and it leads to partnership, and the issue of advocacy and health diplomacy is the only chance we have to change this entire thing. This is an example of what may happen with good programs. This is a study we published in PLOS ONE a few years ago, looking at hospital admissions for bacterial sepsis in Brazil. If you look at the top graph, it was almost 65,000 in 1992, and over 14 years, it decreased to about 20,000 overall admissions for bacterial sepsis. During that period of time, there were immunization programs, sanitation, trash collection, water, nutritional program, etc. The point is that mortality did not change in hospitals. So this is one of the reasons why when we work in areas across the world, we need to do an environmental scan to know where to put our resources. In this case, prevention has worked, but we need to do a lot more work in the hospital environment. And the prevention works. I mean, we should know it, but many a time, I think we tend to go for the sexy stuff, and many a time I have to dissuade my colleagues in the developing world where to put their money. In fact, prevention works, and we know from John Snow, removal of the pumps from Broad Street in England during the cholera epidemic stopped the epidemic dead cold. Prevention works. And in fact, this lady that I saw in one of the townships in South Africa while I was there got it right. As you can see, to be healthy, plentiful water, sanitation, nutrition, decent housing, etc., and then well-staffed clinics and hospital and right treatment at the right time. Now, this is from Canada, and one of the issues that we have to think, as I said, the broader concept of what we are doing is the close relationship between animal and human beings. And zoonoses is a major problem worldwide. We hear about the infections we get with H1N1 and those sort of things, swine, flu, poultry, and avian flu, etc. But this is from Canada. This is a Canadian integrated program for antimicrobial resistance. You don't have to read the whole thing, but the bottom line is, if you look at the human who is hospitalized and gets infected, there are many sort of antecedent sort of issues that lead to antimicrobial resistance. Companion animals, the food animals that we have, aquaculture, wildlife, etc., chemicals, they all play into this. And this is where the broader picture we need to think about antimicrobial resistance. Because if you look at this map, within that circle, there's half of the world's population and 75% of the poultry and swine. So the point is, with air travel and what we're seeing, that we have to pay attention to these sort of things. And when I think about the different paradigm, we have to think of sepsis, at least in children, as a social and economic problem because of poor education-seeking behavior. And if you can do one thing in the world to make things better, is educate young women. This is a graph from UNICEF showing that the longer young women stay in school, you can see the mortality of children decreasing to almost zero, the under 5 mortality. And if we see a graph like that in our ICUs, we would be clicking our heels. So many of the issues that we face, the social and economic issues, are really that of poverty. So when we look at the issue of a child with an infection, you will find that in some places you may have rudimentary transport that take a month's salary, so people cannot use that. People may walk for miles to get to a hospital or a clinic. They wait. There is very little triage system. Children are dying in the line. The very few medications that run out within a few weeks, and the rest of the month there is none. And basic laboratory services aren't there even to do a hemoglobin and smear. So this is the context in which these children are living and dying. But there are innovative ideas and solutions that we can bring to bear, and I think that this is what we should be doing. Education, the question is that there are no physicians, and I'm glad this is a joint session because in many parts of the world that we're talking about, most of the population, over 50%, are less than 15 years old, and there are no pediatricians. It's the same group of physicians and nurses are taking care of both. So the question is, and it's this for another day, is who do we educate? Nurses, village health workers, etc., policymakers, it's very important. How do we prioritize it? And the question is what technology we use. There are a lot of technology that we can use now, leverage technology to help. And whether we educate them at home and abroad is a very broad discussion because in many cases we bring them to our institution to educate them, send them back. What we have in our institutions are not really very relevant. And in many cases, they don't really go back. So this is very interesting to show what village health workers can do. This is for newborns with serious illness, mostly sepsis. Village health workers were trained to recognize sepsis, give antibiotics, etc. in the villages, and you can look at the case fatality rate of those seen by the village health worker is 4. The qualified medical practitioner case fatality rate about 3 times higher, and no treatment unqualified is doubled again. It's not that the village health worker is better than the qualified medical practitioner, but the structure is such that people don't have transport, they have better relationship. The village health worker sees the patients a lot earlier. So hence, if we are going to make a difference in who we educate and where we educate, it has to be context-based. The other innovative solutions for low and middle income countries is to really look at where the different resources are, management in areas in which there are no resources available, little resources and more resources, and this is our area. This is what we did through the European Society of Intensive Care Medicine group working in global health, and this is, I had the privilege of putting this together, looking at guidelines for treatment in resource-limited environment for children. The point is that if you're going to work in those areas, we have to think in terms of capacity building, from increasing strength in community engagement, strengthening competencies at all levels, using guidelines as necessary, adopting technologies, transport, etc., and then evaluation and spreading what we learn. And this is a program that I can talk about it more. We're doing in Bangladesh right now, but it is the issue of building capacity that is most important. One example, this is just published in Pediatric Critical Care Medicine. A colleague of mine, Gregor Polak from Malawi, there are no PICUs and those things. There are a lot of children with sepsis. They can't comply with the usual gold standard guidelines, and by the time the children arrive to them, they're dying. So what he did was look at severe sepsis. He did several things. Malnutrition and sepsis, elective surgery. He made sure that they fed these children. If they were elective surgery, we can hold back that. Implement this safe surgery campaign. Looked at referrals from outside to high dependency units so they all did not have to come centrally. Did not fast the patients for a long period of time because the kids were missing antimalarials and antimicrobials. There were specialists, no specialists, so he trained sort of anesthesia assistant, and then he took care of trauma and high maternal mortality rate by educating there and decreased the amount. Clearly, we can't wait with research. This is from Declan Butler a few years ago in Nature, in which the clinician is on one side with a test tube doing the research, the laboratory doctor is doing the research. The clinician is on the other side waiting for the results, and because of lack of knowledge translation, you can see where the patients are in the middle there. So we have to be a little more sophisticated now and do comparative effectiveness research. We have to look at improvement and implementation science as a way to bring things up to scale very quickly. And these are some examples: intervention package by childhood health workers, in Pakistan, reduced neonatal mortality. In Zambia, reduced drug overuse for pneumonia. And you can see provision of low-cost antimicrobials and in clinics and homes in several countries, Bangladesh, Egypt, Ghana, Vietnam, and Pakistan, all are saving lives. The problem of late deaths, as I mentioned, we looked at post-discharge mortality, and right now we have a PhD student in Uganda looking at this because they don't have, many of these places don't have the resources to follow all these children. But if we can identify the group that really needs follow-up or who are more at risk of dying, we can save more children there. The importance of advocacy. This is very important. In fact, we all know about cancer, and I'm always intrigued by cancer across the world, how everyone knows the pink ribbon and cancer. Well, Sidney Farber, who was at Boston Children's Hospital about 60 years ago, spoke about disease. He understood it. He said, at any disease, the campaign is much like a political campaign. You need icons, mascots, images, slogans, and whatever. And a disease needs to be transformed politically before it could be transformed scientifically. So we need to get advocacy going very quickly. We haven't done a good job in sepsis. And there are 2 or 3 studies. This is one from across the world, but we had a few in the United States also, where, as you can see here, have you heard the term sepsis? In the red are those who said no, and as you can see, 80 to 90% said no. In Germany, it was 50-50, and that's because of a large sort of effort that was placed there by a few individuals. So we have not done a good job. Now, it has been said that a disease needs several things. It needs a prophet, a prophecy, and it needs a revelation, like a religion. And in 1969, it all came for cancer, and it needed a book. There was Alexander Solzhenitsyn's book on the cancer ward, the British state of cancer ward. There were 3 movies on cancer, Love Story on leukemia, Bang the Drum Slowly, I think that was Hodgkin's disease, and Brian's song was testicular cancer. And New York Times had over 450 articles on cancer, prompting Richard Nixon to say, do you want more money? Do you want more money? They said, the fact is that the prophet was Mary Lasker, who came along. The prophecy was, we will cure cancer. The revelation was, men had gone to the moon that year, and they said, if you can go to the moon, we can cure this here on Earth. And there was the book. So everything all came together. We need the same sort of thing with sepsis. And hence the Global Sepsis Alliance, you can go on the website and see it. We have had a very successful World Sepsis Day just September the 13th. The next one is coming up next September the 13th, and I hope many of you will participate. So finally, a few concluding remarks. The question is, in many cases we can say, well, that doesn't affect us. It's not in our world. The fact is that it is inhumane. There is a moral obligation. As Martin Luther King said in 1959, of all forms of inequality, injustice and health is one of the most shocking. And health inequities and disparities will be a new era of civil rights. The fact is that we can see it playing out right now in the United States. These are 2 sayings from the American Society of Tropical Medicine presidents, and it relates to children, it relates to infections, infectious disease. No country can live to itself in disease prevention. A failure of one is a failure of all. I like the second one, and he was talking specifically to children here. The solutions to their problems, the problems of children, are ours. How they and the disadvantage around the world fare is what will clearly determine the destiny of us all. So, should we care? Well, we can look at it one of 2 ways. We can say it's a human rights issue, and those who feel a moral obligation will do something about it. But secondly, there's a consequentialist sort of issue here. It's our own health is at stake. So when you look at the air patterns, the air traffic patterns for one day, and you can see where we've all come from, and the issue of spread of artemisinin-resistant malaria, totally drug-resistant TB, cholera, HUS, dengue, etc., you can see how quickly it spreads all around the world. So I think that I hope I've convinced you that we all have a stake in this, and we all should do something about it. And I'd like to thank you for your time.